Thank you. All right, I'm going to call this meeting to order. And if we could take roll, that'd be great.
Senator Crum. Senator Hutchings. Senator Scott.
Here.
Senator Steinmetz. Chairman Brennan.
Here.
We have a quorum. We have
All
a
right.
quorum.
Thank you. All right, welcome everybody to Senate Labor Health. Hopefully, I'll just make like a brief, think everybody's been in these meetings. Be nice, address the chair, turn off your cell phones, be cordial, simple things like that. And with that, we will start with Senate File number 4, Medicaid rate increases, EMS services. And if the department wants to come up and talk about this bill, and I guess I should probably introduce this bill a little bit. This bill was one that has come through the interim committee, and the basics of the bill is it increases the reimbursement rate for emergency medical services to 100%.
So, Madam Chairman, members of Senate Labor, my name is Franz Fuchs. I'm the Deputy Director of the Wyoming Department of Health, joined here by Jesse Springer, our state Medicaid agent. Madam Chairman, that is exactly what the bill does. It directs the department to raise our ground emergency medical service rates to 100% of the current Medicare rate. As you all know, there are various payers in the ground EMS world. We have Medicare, was one of the largest. Medicaid, a little bit much smaller market share, and we have a lot of private insurers and other private payers that also pay for ambulance services. So this would essentially benchmark the Medicaid rate to the Medicare rate at the cost of $1.3 million general fund, $1.3 million federal funds for the biennium. So happy to take any questions you might have on this bill.
Mr. Chairman, this has some aspect of just plain a budget increase. Couple of questions. Did it get submitted through the normal budget process as a budget increase, or is it strictly in this bill? That's one question. Second question, does the federal government put an upper limit on what we can reimburse for these services, and does this hit that upper limit?
Madam Chairman, Senator Scott, to your first question, it's in the bill only. This was not in our budget request, so this would not be duplicative of that. And to your second question, it does not yet hit the upper payment limit, so there still is room. We do have a recently implemented ground EMS upper payment limit program. And so this would still leave room for that, draw down additional federal funds for that.
Okay. Madam Chairman, my question is just a little different than that. There, supposing the Medicare reimbursement rate is inadequate, does this constrain us from going up to what would be an adequate rate? We're at 100% of Medicare. What is the actual upper limit that we can go to?
Madam Chairman, Senator Scott, I'd have to defer to Jesse Springer on that question. It's a little more detailed.
Chairman Brennan, Senator Scott. So we have two sets of payments that are going to providers right now. So we have payment for service. So they're billing us for direct service, and we're paying each claim. So for each visit. And then we're settling up at the end of each year through a supplemental payment program, which the providers put in a statewide contribution, and then that's matched federally. So for our primary payment, we are generally benchmarking against Medicare, which I think the bill is referencing. And 100% Medicare is is an estimate of being 100% of cost. It may not be exactly 100% of cost, but it is, that is the idea. Our current supplemental payment program was approved to be benchmarked to average commercial rate. So we actually do a rate survey and we're using average commercial rates for that supplemental payment program. And that's actually the limit that we're able to pay. So we're paying fee for service for the actual trips, and then we're settling up at the end, benchmarking with average commercial rates to take cost coverage above 100% of Medicare currently.
And Madam Chairman, Senator Scott, if I could add, just to give you some context of what those rates, rates are pretty complex with, there's different levels of service, there's mileage included, but on average, if you look at a 911 call for basic life support, on average, Medicaid pays for a trip, including mileage, $349.60. Medicare would pay $576.24. And private pay rate would be $950.80. So you can kind of see the distribution of those different payers.
Can you repeat that, Madam Chairman? Can you repeat that more slowly?
Sure, sorry. So Medicaid is $349.60. That's the average paid. Medicare, $576.24. And private pay rates would be $950.80. And that hopefully gives you a sense of the spread of where those payers are. So this bill would fund us to kind of bring the Medicaid rates up to Medicare, but not up to private.
Okay, and Madam Chairman, my correct understanding then is that what the average private rate would be the limit that we could go to.
Chairman Brennan, Senator Scott, we could pay that. There's, with those two payments, the state is putting the match in on the first fee for service payment. When we're paying for the trips, the state is paying state general funds and matching that with 50% federal funds. On the supplemental payment programs, the provider is putting in the match and the remainder is paid by the federal government. So there's no state funds in the supplemental payment programs. So if you took the first payment up to 100% of average commercial rate, assuming we could get approval to do that, you would be replacing provider funds and federal funds with state general funds. So that's generally why we haven't recommended that. That's why there was not a budget request for this topic. Generally, if you go above a certain level on the first payment, you are generally replacing you're adding more general funds to the system than you need to hit the same amount of reimbursement. So that's why we generally haven't recommended that. The reason this particular bill would not cause an overall loss to the providers is because we're currently capped at 6% of revenue on that supplemental payment program. So they can only assess fees of 6% of revenue and have those matched by the federal government. And the big beautiful bill capped that for non-expansion states at 6%, which it historically had been 6%, and for expansion states at 3%. So we're still capped at that 6% of revenue, and it's collecting that revenue and then getting federal match. I know this is a really complicated. Every time we talk about supplemental payment programs in the legislature, it's one of the most complicated things we do. So I apologize for. We actually have done over the years. Every time one of these comes up, we've done education because it is one of the most complicated, confusing things we do.
Madam Chairman, one of the reasons I'm questioning this is that we're having trouble getting enough emergency medical services across the state. And I'm wondering if part of the problem is that the government, for those that the government pays for, is paying too much below cost. And do we have any notion of what the cost really is?
Madam Chairman, Senator Scott, I think the root of the problem is actually the fundamental economics of it, because even if you pay a very high rate per trip, Some services just don't have enough trips that they can ever make up their costs. And so there's very rural services that may only have 20 trips a year. So you still have to pay for the readiness. You still have to have that ambulance ready to go at all times. And on average, we expect that to cost $500,000. Now, whether that's directly paid by taxpayers or subsidized by volunteer labor, it depends. But you can only bill 20 calls. Maybe that's $6,000 of revenue that you can collect, even if everyone paid. So that $6,000 doesn't really matter what Medicare is going to pay. It's just not enough to offset that $500,000 fixed cost. So really, I think the scale issue is far more fundamental across Wyoming's rural and frontier communities.
Madam Chairman, and okay, in a circumstance like that, what does this bill do to help that situation where we've got to maintain the ambulance and it's going to cost us the 500,000 a year, but we just are not going to earn the kind of revenue it needs?
Madam Chairman, Senator Scott, so throughout the state, we did a study in this last summer that estimated the deficit or that's made up in subsidies, whether that's volunteer labor or excess Medicare from critical access, at about $30 million a year. And so we're adding $1.3 million a year additional revenue on the Medicaid side to that. That's kind of the scope of how much it's doing. But most of that's going to go to providers that have some amount of volume, right? That see a significant Medicaid number of trips. And so those will be the larger cities.
Adding how much? 1.3?
This, Madam Chairman, Senator Scott, this adds 1.3 million annually on net, right?
Thank you,
Annual.
Madam Chairman.
Thank you, Madam Chair. Your answers brought up a lot more questions. So an ambulance comes to the house for a call. I'm not on Medicare and I'm not on Medicaid, but you're still wanting to reimburse via Medicaid. Is that correct? How do you choose Medicaid?
Madam Chairman, Senator Hutchings, the only reason Medicaid is in this bill is because, that's the payer that we control, right? We operate Medicaid. And so that this provides the budget authority for us to expend those funds and tells us to raise the rates. We don't have any control over Medicare. We can't affect the Medicare rate. We don't affect the private pay rate. And for people that are not insured, if they're not on Medicare, Medicaid, or privately insured, they would be on the hook personally
Pay for it.
to pay for it.
Follow up, Madam Chair. What's the rate now, Franz? Or
Madam Chairman, Senator Hutchings, so because there's so many different rates, there's the mileage, there's the fixed, there's all kinds
Gotcha.
of different things. So I gave those 3 benchmarks. So the rate now for Medicaid on average for that 911 response at a relatively low level, the basic life support is $349.60.
Gotcha.
And that includes the mileage and the fixed fee.
Okay, Madam Chair, one more if I may. Something you said, and I don't know, I could have gotten it wrong, but it seems to me, and I could again be wrong, you're choosing Medicaid to help offset this cost just because of the way our state is situated, and you're saying that 500,000 a year to pay for the ambulance services? Is that what you kind of said? We need that to kind of maintain them, but we're not getting the calls that we need. So what made you choose Medicaid? Is it just because, like you said, you have oversight of that to choose them to make the payment?
Madam Chairman, Senator Hutchings, the $500,000 figure is an estimate of the costs for that ambulance service, how much it costs them to run their service,
Right.
as far as staffing it 24/7, if they had paid staff. It's not something that we pay or Medicaid pays. It's essentially the cost to the provider, and that's just an average. And that cost pretty much has to be paid no matter how many calls you serve because you have to be ready to go, right? So if you have very low volume, it's just very hard to pay the bills. And that was the point of that conversation, was kind of saying, you know, if you only had 20 calls, there's no way you're going to pay $500,000 to make up that cost difference. So that's, I guess there's a bigger problem than just the rate, right? It's a bigger structural problem is what we were getting at. But this bill certainly helps in a way by adding more, increasing the rate for the trips that we do pay for
Okay,
to Medicare levels.
all right. Thank you.
Thank you, Madam Chairman. I'm just wondering, since we know a little more about the Rural Healthcare Transformation Grant now, if this bill is still needed with that coming in. I know that there was some talk about that focusing on EMS and understanding how that works with our small communities. So I'm wondering, this is a $2.6 million ask for the biennia going forward, ongoing expense. If we need to investigate that before we push this forward, or what are your thoughts on that?
Madam Chairman, Senator Steinmetz, our application for rural health transformation does devote a significant amount of that towards EMS and small hospitals. But the idea is to kind of, one, provide incentives for them to regionalize and consolidate. So we basically say, hey, you have a bunch of small services in this area. If you all are willing to voluntarily come together and maybe share some administrative overhead, work on trying to coordinate the calls better, have interoperable equipment, interoperable dispatch, we will pay you an incentive payment to transform how you do business. And that incentive payment is designed to kind of cover some of those fixed costs. It does not supplant, and it cannot supplant. Legally, we are not allowed to replace any other payer's funding. So we can't say, hey, we're going to replace Medicaid funding with rural health dollars. So it's a different purpose. It does, both of these help the providers. This helps on the fee-for-service side. Rural health transformation helps on the business model and the sustainability based on trying to match that fixed cost a little bit. But it's not, none of it is a silver bullet. And we see it kind of working together to try to help the system.
Follow up. Thank you, Madam Chairman. Well, and I would think the fee for service is based on the fixed costs, right? So if we're offsetting some of the fixed costs that these small ambulance providers have, for example, LaGrange Fire Department, if we're offsetting some of their fixed costs to be ready when they go out on a call, then that fee for service should be reduced. Am I seeing that incorrectly?
So Madam Chairman, Senator Steinmetz, I think in the case of LaGrange, then they would maybe have 5 Medicaid calls a year, maybe. Most of the people are going to be on Medicare, and I don't imagine they serve more than 50 to 100 calls in a year. So for that particular small EMS system, this bill won't have much of a difference, right? It's not, they don't have the volume to actually capture the revenue that's coming into this from this bill. Whereas rural health transformation will make a disproportionately bigger impact for them, because it's really focusing on those fixed costs and saying, hey, if you guys, work with other, Torrington EMS or other, smaller systems within your area, and we will sort of help you subsidize the fixed costs of those ambulances. That's the intent of the application for rural health transformation. So this bill and the Medicaid reimbursement would be very small amount for them, I would imagine, just based on volume, because fee for service volume is based on the number of runs you do. It's not based on your costs.
Okay, thank you.
I'll just, because we've talked about a fee for service and a fixed cost, and just for everybody, and if I explain this out of line, correct me, but your fixed cost is things like you have to have the ambulance, you have to have maintenance on the ambulance, you have to have your crew on the ambulance. Those are fixed costs that have to be available 24/7 to run the ambulance service. What Medicaid in this, that this bill is applying to, but we're also talking about, because you know, we're benchmarking against Medicare, and then there's the private insurances, or it could be self-pay depending on who you are. But what you get charged then is that fee for service, that cost that's above and beyond that it costs to actually provide whatever services that are needed by the ambulance crew once they go out. And I imagine those actually vary differently depending on what they have to do once they're out there. Is that?
Madam Chairman, generally the rates that they bill and get paid are pretty standard across the board. So Medicare has a standard rate. They do vary by location. There are rural and super rural modifiers compared to urban codes. But generally speaking, Wyoming is all going to see every Wyoming ambulance system, if they bill Medicare, is pretty much going to get the same rate, depending on the service they provide. So if they do advanced life support, the rate's a lot higher than if they do basic life support, because the credentials of the staff to deliver that service are so much higher. But aside from that, at the end of the day, they're gonna have to make do with whatever they're paid and how many runs they do, collect that revenue, and then supplant, whether it's tax dollars or hospital revenue or fire department. You know, there's other payment sources out there that sort of subsidize that gap. The smaller services kind of have to cobble that together and figure it out. The bigger services can definitely make volume work.
Committee, any other questions for the department?
Just a really quick one. I don't know if Senator Scott asked, as I was writing, I might have missed this, either one of you. How much will this bill help you guys? For 2 years, right?
Chairman Brennan, Senator Hutchings. Franz mentioned the exact rates for one of the lines of service, but we're paying about 66% of Medicare as of our last benchmarking report. So we consider Medicare to be cost. It's not a perfect barometer of cost. I think there's a lot of discussion about is that a perfect barometer of a cost for a very small service? But we're using generally in our system Medicare as a barometer of cost for moderate sized town or bigger town. It probably is not too far off. We're paying 66% of that. So, you know, what this bill is doing is saying we're going to pay 100% of cost for these trips. That's really just fundamentally, you know, that 34% difference. They're taking likely a loss on Medicaid trips at this time on their fee for service basis. The reason we haven't brought this, because that's pretty low. The reason we haven't brought this is because in the recent years, there's been a supplemental payment program. So it's, you know, for us, we consider supplemental payment programs when we're considering budget requests. But that's why it's not in the department budget request. But generally, if a service hits that low of a cost coverage, we would bring a budget request. But we always have to consider the supplemental payment programs, and that's why we did not.
Chairman, what percentage of the services are provided by private outfits, specialized government agencies, and by your city and county fire departments? And I'm trying to figure out, are we just supplanting city and county funds here? What's actually happening with this bill?
Madam Chairman, Senator Scott, that's a good question. It's really a mix. Again, not a helpful answer there, but that we actually probably have a lower percentage of fire EMS than the national average. I think there's only a couple, Jackson and Laramie, do run a fire EMS model. Cheyenne has a very interesting situation where we have the fire department shows up to most of the calls, but so does AMR. And so AMR will, American Medical Response, which is a commercial ambulance. And so you typically will have, you know, 80% of calls, you have a fire truck and the ambulance. And then AMR will bill for the service, and the fire department, of course, has the tax base. So there is some interesting aspects to this, but you've seen one EMS system, you've seen one EMS system. And so I don't think I personally don't think that a lot of this would be supplanting tax dollars. But again, that's just an estimate. We haven't fully looked into that. how many services we'll be receiving Medicaid dollars and if they would offset that with tax dollars or not.
Hate to belabor this, but I just have to know for my own edification. So as a business owner, my business is there. I have my utility costs, all of my fixed costs that we're talking about. And when I mark up my goods and services, all of those fixed costs are rolled in. So I don't understand, and maybe Charlie can educate me, and I'm sorry if it's a dumb question, but everyone always said there wasn't such a thing in the legislature. So why are the fixed costs for readiness and the utilities and all the, the building costs and the maintenance all rolled into the cost when you provide a service? At the end of the day, this is what you have to operate your system. And if that isn't in the costs that are being billed, because if I don't do that, I lose my tail as a business owner. That could be a lot of the problem with our model and why it's unsustainable, because we're not. And if this bill helps correct that, then I can vote for it. If not, then I'm probably a no. So if you can help me with that, that's where I'm at.
Thanks.
Can help. This, what we're getting at here is one of the fundamental problems we have in our healthcare system. And this is really an extreme case of it because of the extremely high fixed cost. But in general, we have a high fixed cost on much of the hospital services, for instance. Medicare sets their rates depending on what Medicare thinks they ought to pay. And I think they base it really on what does it take to break even in a large urban teaching hospital type setting. It assumes a much higher percentage of the utilization of the facility, of the capabilities than Wyoming can generate, because we, in general, have a lower volume of business. Say a procedure that you could do 400 a year in the hospital setting, a large urban setting might do just that. Our hospitals might do 100 or 200 a year, half of that. And your fixed costs eat your lunch. And Medicare does not recognize that. And the trouble is that Medicare is getting to be the rate regulator by regulating the reimbursement for 50 to 75% of the book of business, depending on what you're talking about. And it's the mechanism whereby Medicare discriminates against us. And Medicare, I don't know what they do in this ambulance case. In the hospital case, they will not allow additional charges, or will regulate how much the additional charges can be, no more than 20% typically. And so they're behaving essentially as if they were a public service commission regulating the rates, but they won't allow us to charge enough to survive. And that's a good part of the trouble with our system. This is a specialized case because the ambulance fixed cost is so high in particularly the smaller units. We're just going to have to find another way to make the ambulance services viable, and that probably means county and city fire departments doing it, particularly the county ones in the rural areas. And I can't figure out how much this bill is actually helping that. It will help some because we're clearly having trouble maintaining EMS services across major parts of the state.
Thank you, Jen.
So I hope that helps you.
Helps me.
All right, thank you. Any public comment on this bill? Come on forward. Could you introduce yourself, state your name for the record?
Thank you, Chairman Brennan. Committee, I'm Tom Laycock with AARP Wyoming. This is a fascinating conversation because for the last couple of years, we've been diving into this question about how do we help sustain EMS around the state with Hospital Association, Department of Health, local EMS, Medical Society. It's been a great conversation. So many things that you find out that you never thought you would know about this whole issue. Senator Steinmetz, you hit the nail on the head. One of the fundamental questions is EMS a service or a business? And it turns out it's maybe a little bit of both. In terms of the impact that we think this will have, EMS is sort of that classic eating of the elephant, right? One little bite at a time. And so we think that being able to increase this payment will be a little bit beneficial in terms of being able to help folks in those EMS agencies pick up a little bit more money. You're also going to look into that the regionalization issue. That has worked really well in northern Wyoming. It's a conversation that needs to continue, and we think that the money's there to help continue that. You're also going to hear about in the healthcare transformation program, the question of, how do we help our EMS agencies by actually being the centralized biller? Because we've gone in front of the counties and said, is this something that has legs? Is this something you'd like us to try to do as a state? And, the answer has been, yeah, Jim's really great at picking someone up when they have a heart attack, but, we're not always sure exactly how to do the billing. And so we're not getting the reimbursement that we're actually entitled to. So it's a fascinating conversation. We could talk about this for hours, and we would drop like so many little pieces of trivia that, that's what kind of makes it interesting and fun. It's a really interesting exercise. The reality is, though, over the past 10 years, we've had 16 EMS agencies either fold into someone else or just go away completely. And so we know we're struggling. We know that we're 200 people, EMS department people down from where state EMS people tell us that we need to have sort of, what they would consider to be sort of best case scenario within the state. And so it's something that we think this helps. It's not the silver bullet, but it's one of those bites. So that's why we're certainly supportive of it. I think I told you guys last summer that we actually did some survey on how the people within the state feel about EMS. We found out a survey of 1,003 Wyomingites, age 18 and over. We found 8 in 10 believe that EMS should be an essential service, and 73% of Wyomingites believe communities should pay for EMS the same way they do for police and fire departments. And so it's something that really sort of captures people's attention because they don't really think, you pick up the phone, you call 911, someone shows up, but the more you kind of go down the rabbit hole in terms of how that happens becomes really fascinating and really complicated. So like I said, this seems to be one bite at the elephant, and we'd appreciate your support with it. Be happy to stand for questions.
Questions. You said we've lost 16 EMS agencies. Over what period of time and out of how many total?
Sure. So that'd be Chairman Brennan, Senator Scott. That'd be over 11 years because that number was from last year. And I do have 90 some. Okay. Mr. Bully says 90 some. I have that on another Google Doc that I can track that down.
90 before or after the losses?
Before, I believe.
Madam Chairman, Senator Scott, I think that's current numbers. Department of Health can probably help us, but I think that's current numbers.
Mm-hmm.
We're down to 44 now?
We're down to 44.
Down to 44 services.
Okay.
Madam Chairman, 44.
Okay, now you've confused me.
We're down to 44 now, Senator Scott.
Not 16, but 44.
Total right now.
So we've,
The state of Wyoming would have 44 operating EMS agencies. Sorry,
Currently-
I should have gone through the chair. I apologize.
that's okay. So currently we have 44 operating EMS services. We've lost 16 in the last 11 years. Okay. Any other questions? Senator Steinmetz.
Thank you, Madam Chairman. You said some of those folded into others. Is that a form of regionalization or is that a loss? So is that a win for us if that's what we're trying to go for? And then, how many of them were consolidations and how many were just closures?
Chairman Brennan, Senator Steinmetz, I don't have those numbers right in front of me in terms of which ones. Franz put together a dynamite report 2 years ago on this topic, and that does exist there. I'm happy to send that your way. But in the cases where it makes sense, it's absolutely a win. Thank you.
Madam Chairman, Committee. Madam Chairman, Committee members, Eric Bully with the Wyoming Hospital Association. I don't represent the EMS Association, but we do work very closely with them and because we have a lot of commonalities. And you've asked some terrific questions. Senator Scott, one of the questions you ask is if there's an upper limit to what we can charge. And I think the answer is actually no. We can, or what Medicaid can pay. It's up to what the general fund puts in. And I think Medicaid could actually exceed commercial rates if they wanted to. And we've seen situations, Utah is a great example, where for that same code that we're paying $300, they're paying almost $1,000 out of their state funds. The upper payment limit or the supplemental payment programs that we talk about really has no bearing on this. That's one way for us as providers to access additional federal funds without it costing the state any money. And so we've enacted that, and you helped us pass legislation to do that. It has nothing to do with this conversation, in my opinion. Senator Steinmetz, you asked a great question about your business, but the reality is you can build that into your business and you kind of can project and perform what you're going to see as far as revenue and all those things. This is definitely a service. It's not a business. And so in those small communities, the fixed costs, we can go ahead and charge whatever we want. So we could charge $5,000, $6,000, $10,000 for every call. We're only going to get paid what Medicaid will pay us, what Medicare will pay us, and what our commercial rates. So it has no bearing on it. It just means that we charge too much and then we write it off. And so it's a very different model than from a regular business. And I think that's one of the things that we see so often in healthcare is that, and if somebody takes uses your services, comes into your business, they're going to pay when they walk out the door. In a lot of these cases, we're not going to get paid for any of it. We might get called to help someone transfer from the bathroom to the bedroom. And we can't bill for that. And so or someone comes in and receives hospital services and they don't pay for it. So that's a very different part of the business model. I do think the Rural Health Transformation Fund has a place in this conversation, but I think Deputy Director Fuchs and Jesse Springer did a great job talking about that. The rural health transformation can help us with regionalization, and we've seen some success. So up in Campbell County, Sheridan Memorial, Campbell County, now Newcastle, they've partnered. I actually think they're providing services maybe all the way down to Lusk right now, but it's at a loss still. But they've found a way to work together. We've seen regionalization over in the west side of the state where there were 3 services in Star Valley is a good example. 2 of them were independent. 1 was under the hospital. The 2 independent ones couldn't function. And so finally the county commissioners talked with the hospital and said, hey, you better take over these services. And so they did. There's some benefit to that because they're able to bill under the hospital umbrella and they get cost-based reimbursement because that's a critical access hospital. They're still losing money. And so this is simple economics. We either need to decide, and I think this is a question the legislature needs to decide, and this is what we've been working on for a long time with the governor's healthcare task force. Do we want EMS services in our community? Do we want people in LaGrange to know that they're going to have an ambulance show up if somebody has a heart attack or if somebody has a stroke or if there's a car accident? Or do we want to rely on our pickup trucks and driving people into the hospitals or wherever it might be? So this is 1.3 million general fund, 1.3 matching fund. So it's $2.6 million is what's being asked for. It's a Band-Aid on a big problem, but it's going to help. I think the other thing that I would just offer is where there are private services, and Cheyenne is a great example of that. We have AMR. They're here because they're making money and there's enough critical mass, there's enough calls to make sense. But we're not talking about the Torringtons of the world. We're not talking about the Newcastles where they don't have enough volume to make money. And when you look at an aging population, more than likely it's going to be either Medicaid or Medicare, none of which cover our costs. And I always push back. I think Medicare is the worst barometer to use because they only pay about 80 cents on the dollar for anything that happens. And so if that's our golden rule and we're going to try and get to Medicare rates, we're still losing money on every single situation. And so I would ask you to support this and help us move it forward. I think it will help, and especially some of our struggling services. The other thing with rural health transformation, we've got a ways to go. That money's going to roll out. And yeah, I think we can do some great stuff on a regional basis, and that can help us get those formed, but we're still going to have the ongoing situation for every single run. What are they going to get paid? And then how do we make up what we've already expended? And so I would just ask for you to support this, and let's see if we can help our EMS services around the state. With that, I'd answer any questions.
Hello, thank you. My name is Micah Richardson. I am with the Wyoming Women's Foundation at the Wyoming Community Foundation, and here to speak in support of this bill as well, recognizing it can do something. It goes a way towards the issue of EMS services. And I come speaking about this because according to the Department of Health in 2024, there were 703 EMS services related to OBGYN and needle care. And of those, 303 were requests for labor and delivery. And so as those services go away, we are leaving moms and babies potentially in some not so good places. And so anything we can do to find solutions, even if they are just, you know, taking a bite at the apple here and there, or at the elephant, if you will, I think that's important to be thinking about all of our options and trying to tackle it from a lot of different angles. So thanks so much.
Thank you. Committee, any questions? Thank you.
Thank you, Chairman and Committee. My name is Marguerite Herman. I'm sitting here wearing my hat today for Healthy Wyoming, which is a coalition group that works on many fronts for accessibility and affordability of healthcare in Wyoming. So it's multifaceted. We have a lot of partners nationally and around the state. And I'm just here. I don't have the expertise of the other people who have testified, but just to say that we are in support of this. Once again, as a piece of a very large, complex puzzle, which is healthcare in Wyoming. As we all know, we have the highest cost in the nation because economies of scale, et cetera. But anyway, we stand in support of this bill. I don't know if I can answer any questions, but I'd try if you had any. Thanks.
Thank you. All right. State your name. I think I forgot to mention, if you, for public testimony, just come on up and fill the chairs and welcome. Just state your name and.
Thank you, Madam Chairman. My name is Kevin Reddy, and I'm the president of the Federated Firefighters of Wyoming. We represent the majority of the career firefighters who respond to the majority calls of service in the state of Wyoming. And we also support this bill. When we're looking at EMS and you're looking at the cost versus the reimbursement, any little bit would help. And obviously, if we lose some of our partners in EMS transport, that puts a bigger burden on our fire departments. So thank you for your time.
Any questions? Okay. Anybody else in the room for public comment? Do we have anybody online? Okay, with that, we'll close public comment. Committee, what's your pleasure?
Move the bill.
All right, it's been moved by Senator Crum and seconded by Senator Hutchings. Committee, any discussion on the bill?
Madam Chairman, it sure isn't going to solve the problem, but we are paying an embarrassingly small share for the services that Medicaid is using here. And I think it's incumbent on us to bring that up to a more reasonable level. So I think the bill is important, but we've got to recognize it is not going to solve the problem.
Thank you, Senator Scott. I think that this is one of the more fascinating things about healthcare is the way that reimbursement and charges work, and it would never make for a good nor profitable business model. So because of that, I would agree that we should move this bill forward. So any other comments Questions? All right, we'll take a roll call.
This is a roll call vote for Senate File 4. Senator Crum,
Aye.
Senator Hutchings,
Aye.
Senator Scott, Senator Steinmetz,
Aye.
Chairman Brennan.
Aye.
Madam Chairman, that is 5 ayes.
Okay, so this will go up. Anybody want to carry this bill on the floor? Senator Scott, you got it. Thank you. Okay, next up for our consideration is Senate File 6, eligibility for Medicare criteria. This bill is another bill that was sponsored from the Interim Labor, Health and Social Services Committee. This one is really codifying current state criteria for Medicaid eligibility. And I won't go through the whole thing line by line because we did work it in the interim. But if the department would like to come up and talk to us about this bill.
Chairman Brennan, we did discuss this bill during the interim. Since that time, we were contacted by a few different staff members and also by the Department of Family Services, just to make sure we weren't doing something unexpected. So we did propose an amendment to the bill. Generally, the bill does a good job just capturing the current status quo, the as is today of what Medicaid is covering. And being clear that no extensions or additions of coverage can be done without the express authorization of the legislature. So I think that was the goal of the bill, is to denote what's happening today and to also lay out an express process for adding additional groups if that was desired by the legislature. I don't know if everyone has the copy of what we submitted.
So we do have the copy of what is submitted. I will say that we were only handed this right before the meeting, and so I will we can go through this and then from there we'll decide maybe what to do with that.
Chairman Brennan, would it be okay if I walk through just the changes? Would that be acceptable?
That would be acceptable, yes.
So the first one is in provision E, we already do. We're verifying citizenship or that someone or group is legally residing and is able to be in that group. However, for children that are in the custody of Department of Family Services, due to other statutes, we are charged with providing healthcare to those children, whether or not they are citizens. So we provide, the Department of Health provides the insurance for all children that are in Department of Family Services custody. And then we are able to receive federal match for citizens legally residing. And we have a smaller group of children. It's a very small number, like 5 or 10 a year, that are through the process as a DFS are found to be non-citizens, but they're still taken into DFS custody. And Department of Health, by other statutes, is charged with paying for their health care. If we are prohibited from doing that, that cost would shift from Department of Health to Department of Family Services, because they're still going to have those kids in custody and they're still going to have healthcare costs for those children. So we're just trying to be clear, this is a cost we're currently paying for 5 or 10 kids a year. But if we are prohibited for paying for non-citizens, then that would shift. So that's what that yellow text is trying to do in that provision.
Yeah.
Question on that. If you were, if you're paying for the cost, do you get federal 50% for as Medicaid, or are you paying for full cost and if Family Services is paying for it, would they pay for full cost?
Chairman Brennan, Senator Scott, we are paying Medicaid rates for these children using, if they're in emergency room, then we're doing their emergency program, which is eligible for federal match. If we're doing it in other settings, we are not receiving federal match for non-citizens. And if this was prohibited, that cost would shift to Department of Family Services, and they would pay. They're not set up for paying medical claims the same way we are. So they would probably pay some percentage bill charge or have to establish a fee schedule.
But they wouldn't get any federal reimbursement, or would they?
To my knowledge, the Department of Family Services would receive no federal match. And then going to Romanet 3, and then it just goes through additional groups, and really some of this is covering the same discussion. G is trying to lay out that there's children in custody of the Department of Family Services, in foster care, basic foster care, non-citizen foster care, subsidized adoption, or be located at the Wyoming Boys School or Girls School. So the Wyoming Boys School and Girls School, when children go there, that's not a mandatory Medicaid group anymore because they are considered to be incarcerated. And Medicaid cannot pay with federal match for children that are incarcerated. So this group does not meet the definition of the bill of mandatory populations. And that's why we are adding more specifics for groups that didn't meet that threshold of being a mandatory population. So this is below that line of within the existing bill of saying these were existing mandatory populations. The second is a 1115 family planning waiver that was filed, to my knowledge, over 20 years ago and has been renewed since then. From my research, I have not found where the legislature specifically authorized that waiver or authorized it in a budget footnote. It was done under the powers of the Medicaid director, which is a different part of statute. But given the language of the bill that says that a waiver has to be expressly authorized by the statute, we're calling this out. We had already planned to phase this out when it expires, mainly because it has less than 10 people using it a year. And we're at the point the administrative costs of the waiver are exceeding benefits. So we are in the process of letting that expire. But by the language of the bill, we would need to phase that out early, which would trigger special handling with the federal government if we end a waiver early. So that's why we're asking for it to go to the expiration date.
Can I ask?
Sure, Chairman Brennan.
Thank you. So in and correct me if I'm wrong, you're talking about the 1115.
Chairman Brennan, that's correct. It's 1115 family planning waiver.
Okay.
In our system, it's called Pregnant by Choice.
Okay, and so that is being expired federally. So is there a need to even place that in this bill at this time?
Chairman Brennan, if it is not specifically called out in this bill, we would need to expire it earlier as specified by the bill. So any group that does not meet this bill would need this. I think we would need to end this June 30th, 2027, based on the language of the bill. So either that phase out provision that says any group that does not meet this must be phased out, or this carve out needs to exist, or we just need to reconcile it, or if this is not called out, we'll begin the process of ending the waiver once this statute passes.
Okay.
I think I can remember, but we particularly did authorize in the early 90s. Probably a similar but predecessor program at the federal level. So I think there was at one point, Madam Chairman, an authorization to do this, because I can remember Senator Barbara Cuban being the one that was pushing it, and she was in the state Senate for 2 years or 4 years, right in that period.
Chairman Brennan, Senator Scott, your memory, I tried to do statutory research and also budget footnote research to find the authorization, given the time frame. The specific 1115 waiver, it may be this may be a successor to a previous program that was authorized. And the mechanism just changed, but honestly, I kind of exhausted the level of legal research I was able to do. So if that's the case, this provision could be removed. I'm sorry. And then we have the Employee to Individuals with Disabilities program. We thought the disabilities provision covered this group, but because this is an optional program, the existing mandatory individuals with disabilities, it doesn't quite cover the Social Security. These people likely have disabilities that would meet SSI standards, but they are not, because of income, meeting SSI standards anymore. So the sad thing is once your income increases, Social Security Administration says you're not disabled anymore. In this case, the state actually does its own disability determinations for individuals with employed disabilities, verifies they still have a disability, and then they continue on this program, which is a great program. So people are employed and it's a way for them to get health care. J is similar. It's an optional program, the breast and cervical cancer treatment. All states participate in both these programs that we're mentioning because they're very seem like logical programs. So the department screens people, and if we find that they have cancer, there is a Medicaid option for those people within certain income limits. And this program treats them. But it is an optional program, and so then the mandatory language of the bill did not cover this specific program. So those are the main groups we found. Really, I think this was called out, but these are really niche, smaller groups, and that's where I think in the first review we just didn't find as many. Each of these, H has less than 10 people, employed individuals with disabilities about 200 to 250 people. Breast and cervical, pretty small program, 100 to 150 people. So that's just we're trying to cover. The other G is not a huge amount of children that are in that situation. And the biggest portion of that is the boys' school and the girls' school.
Thank you. Yes, questions?
Thank you,
Senator Hutchings.
Madam Chair. So Jesse, looking through this, you've added these, but you're saying they don't necessarily have to be added?
Chairman Brennan, Senator Hutchings, if these are not added, the optional groups, we as the department would be directed by the legislature to stop covering them based on the language of the bill. So the language of the bill laid out these types of groups: disabled, approved waiver, mandatory population. So mandatory population is children, pregnant women, family care adults, which is 48% of the poverty level. Individuals on SSI, all those are mandatory populations. These are not mandatory populations. These are optional populations. They're options that all 50 states have taken, and these options were taken in many cases 20 to 30 years ago. But these are optional populations under federal law. So just basically, if we don't delineate them, then we would cease covering them. And in some cases, some of these would be cost shifts. So G would be a cost shift for the Department of Family Services. So they will likely come and say, if we stop paying, if Department of Health stops paying, Department of Family Services will show up with the same amount of bill and say, please let us pay for this. And then there'll be a debate about who pays for what. H may be my misunderstanding, but in a case, I'm just sharing that program is also still planned to be expired just because it's not being used. Given the marketplace and other changes to pregnant women coverage, it just is, women are just not enrolling in that program. And then I and J, I think, are very well-known programs, but they're just they're considered to be optional under federal law.
Okay.
Senator Steinmetz?
Thank you, Madam Chairman. Do you have a price tag associated with this amendment? I mean, how much is all of this optional population?
Chairman Brennan, Senator Steinmetz, I could go find what this is. The bill is intended to capture, the original bill is intended to capture the as-is population. So I saw this as being supportive of the original intent of the bill. The original intent of the bill was not to be a cost-cutting bill. And I believe the original fiscal note is a zero impact. So if these things are not delineated, then the budget, it would be a budget cutting bill. So this I saw as just being supportive that with this amendment, the bill should be cost neutral, should have zero financial impacts, zero additional costs to the state. Without this amendment, we could go calculate what each of these groups cost. We have that in our annual report for I and J and H. G is a little bit more complicated. I would need to spend just a little bit of time to delineate out those different groups.
Any further questions from the committee? All right, thank you. Any public comments? Did you have something else?
Sorry, Madam Chairman, we just had some dollar figures if it would help Senator Steinmetz with some of those numbers. So for example,
Please.
on the EID population in 2025, there were 275 enrolled members. And the expenditures that Wyoming Medicaid expended $1,257,779 on care for that population. Unfortunately, some of the other groups, that's the only group that's specifically delineated, broken out in these tables. We'd have to do more research as far as the pregnant by choice and the foster care kids and such. But that gives you a sense of ballpark, that many people in that expenditure.
Right. Thank you very much. Any public comment on this bill? Is there anyone online? All right. They ready? Okay. If you'll state your name, introduce yourself, and I believe we're ready.
Good afternoon, Madam Chairwoman, members of the committee. My name is Jen Lowe, and I'm the Executive Director for Healthy Wyoming. We are a nonprofit that advocates for affordable and accessible healthcare in Wyoming. I'm here to express concern about this bill as it locks Wyoming into today's restrictive Medicaid rules and makes it significantly harder to respond to future health and economic challenges. First, the bill freezes eligibility at whatever is in place on July 1st and then says no future expansion eligibility can happen without new legislation. That may sound simple, but in practice, it ties the hands of future lawmakers and administrators who may need to act quickly when circumstances change, whether that's a recession, a hospital closure, or new federal options that would benefit Wyoming. Second, Wyoming already has one of the higher uninsured rates in the country because we have not expanded Medicaid. Independent analysis show that covering more low-income adults would significantly reduce the number of uninsured people and the amount of uncompensated care our hospitals and clinics absorb every year. By making any eligibility change a heavy political lift, this bill effectively chooses to keep those uninsured numbers and those unreimbursed costs right where they are. Third, the bill hard codes detailed eligibility criteria into statute. That makes it much harder to modernize our programs as federal rules evolve, especially in areas like behavioral health, mental health, and rural access. Instead of using standard tools like state plan amendments or waivers to keep up with best practices, Wyoming would be stuck waiting for another full statutory fight. I would urge the committee to preserve flexibility. If the goal is oversight, there are better options, such as requiring transparent reporting and legislative review of major eligibility changes without permanently locking in today's limitations and leaving future legislatures with fewer tools than they have now. Thank you for your time today. I'll stand for any questions.
Thank you for your testimony. Do we have anybody else online? Okay. Last chance for public comment. All right, we will close public comment. Committee, what is your, all right, it's been moved by Senator Scott. Seconded by Senator Steinmetz. Discussion on the bill.
Madam Chairman, I've got a number of amendments.
All right,
Madam Chairman, first one is the one that the department passed out. And I would offer that amendment with one exception. And the exception is down in number H. We need to remove, not include the words referred to as pregnant by choice. That's just a convenient reference to the thing. We don't normally put that kind of language in the statute.
okay,
Because it's what's really operative there is being enrolled in the 1115 family planning waiver.
okay. So your amendment would be what was offered to us, except under H, we would say be enrolled in the 1115 family planning waiver, period. Strike the rest of that sentence and pick back up with the next sentence, the Department of Health is.
Exactly.
Okay.
Madam Chairman?
Yes.
I would say on this, I think that that particular one was authorized, and I suspect it was for a predecessor program, and that's why they didn't find it when they were looking. Because I can distinctly remember voting on it.
All right.
And my understanding of the testimony is that we're planning to get rid of it because it costs too much administratively and isn't being used much anymore. But it's a more complicated process if we don't just let it expire the way this amendment can. Is that a correct understanding?
Okay. So we have a proposed amendment by Senator Scott. Any I believe we need a second on the amendment, right?
Sure.
Not necessarily. Depends on who you ask.
Yeah. Depends on how you want to run the committee.
All right, any further discussion on this amendment? All right, all those in favor of Senator Scott's amendment that we propose with the striking of part of that, with striking of the words referred to as pregnant by choice, please signify it by saying aye.
Aye.
All those opposed?
No.
Okay,
I'm an aye.
you're an aye, okay, all right, that amendment passes.
Madam Chairman,
Senator Scott.
Madam Chairman, on page 3, line 19, 20, and 21, in that subsection D, propose amending it to move the words pursuant to department rules from line 21 to after services, so be qualified for services pursuant to department rules. It's confusing the order that it's in right now. And then on line 20, after Medicaid waiver, add or other expansion that the legislature has authorized. So if we authorize something that's not technically a Medicaid waiver, as long as it's been legislatively authorized, it's appropriate. So really a housekeeping on the language.
Okay, so I'm gonna repeat back what I think that we have, and then we can discuss it. So this would then read, be qualified for services pursuant to department rule under a Medicaid waiver or other expansion that the legislature has authorized. Okay, any discussion on that? Okay, all those in favor of that amendment proposed by Senator Scott signify by saying aye. Okay, that amendment passes. Oh, did you get that? Okay, perfect.
Okay.
I think
Um,
Senator Scott has another one.
Yes, Madam Chairman, on page 4, an amendment, on line 7, delete July and insert January, so it'd read January 1, 2006. So we're talking about something that's already fixed in place and can't be changed. And then I've got another amendment in that same area, but let's handle it separately.
Go ahead, Senator Scott, you want to,
Madam,
and then we'll go to Senator Crum.
Madam Chairman, just explaining it, what I'm trying to do is go to a date that's already fixed in place, so it can't be changed. Whatever's in there can't be changed after we enact the thing. And it's just a protection.
Senator Crum?
Madam Chairman. Madam Chairman,
Yes.
I just want to make sure we're not messing anything up by, I guess it's almost called post-dating, that things have taken place from January 1st till February 11th that were, or whenever this bill would become effective, is it messing things up, I guess. I don't quite understand this part of it.
So I think what we're looking to do is just codify what the department is already doing. To my knowledge, there isn't been any changes since January 1, or this would say that. I think that is a good question to ask the department. Have you had any changes since January 1st of this year?
Chairman Brennan, Senator Crum, we very, very rarely change Medicaid eligibility. I think you can see with the groups we cover, it's mostly mandatory and other very sensitive option groups, but Medicaid eligibility is rarely changed. We have not changed any eligibility since January 1st, 2026. So the date, to Senator Scott's point, I don't think it would make much difference. We are making minor adjustments, not to eligibility groups, but to comply with the big, beautiful bill. So for instance, this bill doesn't mention it. We're moving from 90 days retro eligibility to 60 days. Those sort of concepts are being adjusted. We are not changing the actual people we cover, if that makes sense.
It does, thank you.
Thank you.
Any further discussion on this amendment? Okay, all those in favor of Senator Scott's amendment that on page 4, line 7, we strike July and insert January, signify by saying aye.
Aye.
Okay, all those opposed? Okay, that amendment carries. Senator Scott, you said you have one more?
One more, and it is a more substance than the other one. It's on that same area on page 4, and what the language there reads is that you can't have any change without prior authorization by the legislature. What I want to do is put in an exception to that. That is a temporary exception, because you could have a circumstance, Madam Chairman, where we had some kind of a public health emergency. Either some organism evolves to give us the kind of crisis we had with COVID, or some evil actor in the world figures out that we're very vulnerable to an attack by a biological agent, and we have a public health emergency. And I think you want to authorize, if the national people decide, okay, we're gonna take care of this problem and we're gonna pay for it by expanding Medicaid suddenly, you want the governor to be able to deal with that without having to call us in. So what I'm gonna propose, Madam Chairman, is on page 4, line 8, after the words "by the legislature," insert, except that the governor may authorize a temporary expansion in eligibility needed to combat a public health emergency, which expansion shall end 30 days after the adjournment of the next legislative session. So we still preserve the legislature's ability to say no, but we give the governor the ability to act in an emergency if that's what's needed. And Madam Chairman, I propose that as an amendment.
Okay. Thank you. And just to clarify, that was 3 days after the legislature,
30 days.
30 days. Okay, 30 with a 30.
Yeah.
Okay. Discussion on the amendment. Yes.
Could I just repeat back the amendment to
Would you
confirm that?
please?
Yeah.
Thank you.
So that would be on page 4, line 8, after the word legislature, that would be inserting the language, except that the governor may authorize a temporary expansion in eligibility needed to combat a public health emergency, comma, which expansion shall end 30 days after the adjournment of the next legislative session. Is that correct?
Yes,
Thank you.
that is correct. Thank you. All right, committee discussion on the amendment.
Really good.
Okay. Senator Scott, I do appreciate this amendment. I think this covers, we've recently been through a health crisis. And I think we know that sometimes things move different and fast in that, but then this gives the legislature the ability to act on that once they're in session again. So,
Yep.
Okay, all those in favor of Senator Scott's motion signify by saying aye.
Aye.
All right, any opposed? No? All right, that amendment carries. Committee, any further discussion on the bill?
Madam Chairman. Madam Chairman.
We did that one.
I thought we just voted on what he amended.
It was the whole.
I missed that. You gotta be kidding me. I thought we just voted on what he amended in the amendment.
Yeah.
Okay, I was no on that then. I hope she got that.
You were.
Yeah, I was a no on that amendment. I hope you got that, Clayton. Just thought I was a no on the amendment.
Senator Scott?
Madam Chairman, I think this is a pretty important bill. We tried a number of years ago to do something like this and we're unable to get it done, couldn't define the eligibility for the program well enough. I think this is a responsible effort to try to preserve the legislature's ability to control the eligibility in the program. And, you know, we can by statute make any exception that's needed. But this means that if you are going to have a major change, it will have major budgetary implications, and that is something the legislature needs to deal with as a whole. So that's what this bill does. So in favor of the bill.
Thank you. Any further discussion? All right, we'll call the roll on Senate File number 6, eligibility for Medicaid criteria.
This is a roll call vote for Senate File 6 as amended. Senator Crum,
Aye.
Senator Hutchings, Senator Scott,
Aye.
Senator Steinmetz,
Aye.
Chairman Brennan.
Aye.
Madam Chairman, that is 5 ayes.
Thanks. Who would like to carry this on the floor?
I could.
Okay.
Did you get a volunteer?
All right, committee, we are going to spend, it is 1:29. We will go till 1:50, or if we get this bill done before then. So next bill up for our consideration will be Senate File 5, Hospital Bankruptcy Proceedings. This was another bill that was brought to the committee in the interim. That was one that we decided to sponsor, and I'm gonna let Senator Crum is really the expert in this area, so I'm gonna let him explain the bill, and then we will take comment.
Thank you, Madam Chairman. This bill is really a pretty straightforward bill. It's filling in a gap in the Wyoming bankruptcy code. Right now, businesses and individuals can file reorganization bankruptcy, but hospital districts really cannot, because they're not separate from the county. A county could file a bankruptcy, but the individual, like hospital or other things underneath it, would not be allowed to file bankruptcy without bankrupting the whole county. And in many cases, as we've heard testimony, the hospitals are are having financial difficulties around the state. And so what this bill does is allow for hospitals to file reorganization bankruptcy. This is not liquidation. This is reorganization, so they can be allowed time to pay the debts that they've incurred over a period of time. And the idea is this will allow many of our rural hospitals a chance to stay open, where they don't close, that we don't have sometimes 100 miles plus for somebody to get to a hospital if there's an issue, especially up and down I-80 or I-25 in those type of areas. So I really think this is a good bill that kind of fills in a gap in our current bankruptcy code and helps rural healthcare.
Well, seeing as we have a really full room for public comment, come on down. Welcome.
Thanks again, Madam Chairman, committee members. Eric Boley with the Wyoming Hospital Association. And I think Senator Crum did a great job of explaining the bill. And he and I have been involved in trying to help one of our memorial hospitals keep their doors open for the last 2 years. And we believe that if this had been a tool they could have used at that time, it would have taken a tremendous strain and burden off of them while they work through their financial challenges. What I would tell you is that a recent report out of Becker's, which is a big healthcare news analysis of our state hospitals, we only have 5 hospitals that are in the black in our state. The rest are in the red, and we have 7 that are, I guess you would the terminology we use would be critical condition, and we have 3 that are in immediate threat of closing. And you would think maybe it'd just be our smallest hospitals, but it's in every sector of healthcare. And so as we started in this, and you'll probably remember all this testimony, I don't want to belabor the point, but as we started into this, we actually thought the hospital districts had the ability to use bankruptcy already, and that in statute, it only disallowed memorial hospitals, which are owned by the county. They have a board that's appointed by the county commissioners. And the difference is hospital districts, they have elected boards and are a subdivision of the county or of the state, and they have the ability to levy mills. And so that's kind of the difference. But as we looked at it, and the reason we believe that is because one of our critical access hospitals about 3 or 4 years ago actually went through reorganization up in the northeast part of the state. So we thought hospital districts had the ability to do that. But then we found out that under their ownership structure, and because their tax 501c3 status, they were able to utilize bankruptcy, chapter 9 at that point. So when we first came, we were only trying to fix this for memorial hospitals, and there are only 5 of them in the state. But then we realized we needed to take care of the hospital districts as well. So there's 2 sections in here. One takes care of memorial hospitals. One takes care of the hospital districts. And we think that this is a great tool as we see this downward pressure, as we see what's happening around the state. I just have serious concern about the ability to keep our hospitals solvent and operating in all the communities. And I think rural health transformation is going to have us do some great things as far as collaboration and maybe finding ways to create economies of scale and do some innovative things, but it's not going to take them out of the woods. So I'd ask for your favorable vote on passing this and giving our hospitals the ability to use this important tool to make sure that we're able to continue to serve the citizens of Wyoming. And with that, I'd answer any questions.
Committee, any questions? Senator Hutchings.
Thank you, Madam Chair. Mr. Foley, thank you for that additional information. Just wondering on page 3 on line 7 through, well, actually 8, it says that filing of bankruptcy under this subsection shall not require a vote of qualified electors. What's going on there?
Madam Chairman, Senator Hutchins, I think it's because of what we just described as far as the ownership structure or the governance structure. And so those board members have already been voted in. And so this eliminates that process of having to go to the electors because they've already elected that board to go ahead and then utilize and follow the process to potentially use Chapter 9 bankruptcy.
Thank you.
Any other questions?
Madam Chairman, I may have one suggestion. I don't think it's a deal breaker at all, but as I look at section 2, I just started thinking about this while I was sitting back there. July 1st isn't that far away, but one consideration, I don't know, is if we could maybe think about having this enacted immediately upon signature of the governor as opposed to waiting till July 1st. And I don't know if it makes any difference, but there are a few months between now and then. I don't know if that makes any sense to Senator Crum or not.
I think we would be happy to consider that.
Thank you.
Any other?
Well, if I could just, this is totally off the topic, but if I could just take 2 seconds and introduce my new vice president, Kelsey Prestisator.
Yes.
Josh Hannes, you'll remember, was with me for about 7 years, and he actually took a position with the Colorado Hospital Association. And you might recognize Kelsey. She's been with us for the last couple of years working with Blue Cross Blue Shield. And I poached her, and I'm happy to have her come over to the right side of the force and to help us with some healthcare issues. So you'll be seeing her quite a bit, and wait till she testifies. She's smart. I just blabber a lot, but thanks for that privilege.
Right. Yeah, thank you. All right, committee, what's your pleasure? Moved by Senator Crum and seconded by Senator Hutchings. All right, discussion on the bill.
Madam Chairman.
Senator Crum.
2 things. First would be an added benefit for this. This is going to allow some of our small vendors within our community that provide services to the hospitals to get paid. By being able to restructure the debt, it'll help some local services to get paid that might not if the hospital would fail. So this is another added benefit for this bill. And then with that, I would also recommend the amendment that Mr. Boley had, or I guess I would move the amendment of effective immediately on page 3, line 21, and replace July 1st, 2026 with effective immediately on the governor's signature.
Okay. Did you get that? Okay. Any discussion on the amendment? All right, all those in favor of striking July 1, 2026 and making this effective immediately, I think our language is like upon becoming necessary things to become law, or you'll get that wording correct for us. Thanks. Signify by saying aye.
Aye.
Any opposed, say no. All right, that amendment carries. Any other discussion on the bill?
Question?
All right, I will just not quite call for the question. I'm going to talk. No, I want to thank, I think this was one of Senator Crumb's idea and the committee for working in this in the interim, because I do think that this is an important piece for our hospitals, and especially those smaller ones in more rural communities. So with that, we can call the roll, please.
This is a roll call vote for Senate File 5 as amended. Senator Crum,
Aye.
Senator Hutchings. Senator Scott,
Aye.
Senator Steinmetz,
Aye.
Chairman Brennan.
Aye.
Madam Chairman, that is 5 ayes.
Okay, thank you. And Senator Crum has offered to take that on the floor. So-
Chairman.
Yes.
Relevant to the bill, if you're gonna have bankruptcy, you need to fix the problems that underlie it. And I'm starting to talk with the governor's office a bit about some of the problems that are arising from the degree to which Medicare discriminates against Wyoming. Be happy to talk to any of the members of the committee offline, and be happy to talk to the Hospital Association offline as to exactly what's going on and why we're getting into some of the troubles we're getting into. So that's just an offer. Just catch me and I'll bend your till it wears out.
Thank you for that, Senator Scott. All right, our meeting is adjourned.